Hello dear students, how was your NEET PG 2024 exam? Some of you would not be very happy to come back to listen to the NEET PG recall session. Some of you would be excited to actually listen to more of the recall sessions. For those people who are not very brave enough to look at the recall sessions, you'll realize that the more you listen to the answers from different sources, the more you realize the mistakes that you made. For some people, it would be actually boring, but technically, you always have to move forward. Life has to move on. If you're able to get a seat at this point of time, it's amazing. Congratulations. If you think that your performance is below par and you have to go back again to your grind where you have to start preparing, now this is the area where you have to focus on the old question papers, the previous year question papers, and definitely the last recent question paper. So in this particular recall session, we'll try to analyze the question paper and see what are the different areas where we should be focusing on and where we have to revise in case you have to crack a bigger kind of rank. Okay, now this is an image-based question. People said this question had come up. So there are some questions where you don't have the options from my side because I have not received all the options, but most of the questions have almost all the options. Now this question is image-based question. Nobody told me exactly what they asked for, but this is a case of pseudomembranous colitis. And what is the causative organism? Clostridium difficile. Other organisms also among Clostridia can cause pseudomembranous colitis, where a pseudomembrane is being formed. Colitis speaks about the inflammation of colon. So, if at all it bleeds, you don't actually get surprised. Bleeding is not a primary feature of this condition, but if it bleeds, you should not be surprised. At the same time, remember, antibiotic abuse can lead to this. What is the relationship between antibiotic abuse and this condition? Antibiotics, if it has been taken for more than 1 week, they can eliminate the gut commensal bacteria. Gut commensal bacteria are required for fighting against the pathogenic organisms that are capable of attacking your GIT. So when you're suppressing the gut flora, there's a possibility of these organisms becoming very dangerous. And they will be able to have a membrane-like structure caused because of the trapping of the organism surrounded by platelets, fibrin meshwork, etc. And the neutrophilic content also will come inside. Together, they look as if they have some kind of membrane-like structure around the area. Also remember, you can go for endoscopy or sigmoidoscopy to see or take a biopsy specimen. Now, look at this question here. Hepatitis B serology, they had asked for what kind of case the patient is if at all XYZ antigen antibodies were present or absent. Let me not actually tell you for a single concept. I'll give you a general concept to answer any kind of questions related to that. Point number one, you look for HBs antigen. Now this HBs antigen is a reflection of the presence of a live infection and a current infection. You cannot say whether the infection happened in the recent past or in the chronic condition. You can just say there is a current infection. Now, only in case of hepatitis B serology, whenever a specific antigen is present in the circulation, its corresponding antibody still yet has not arrived in the circulation. So, the antibody to this particular antigen can be found in the circulation only when this antigen disappears. So, when you have anti-HB S antibody present, it's an indication that the live infection has been aborted or the live infection has been eliminated. Right now, there is no live infection. That is what you understand from anti-HBs antibody presence. Now, when you have HBs AG, there is one more antigen which would be present at the same time as HBs AG, which is HBcAg. But the problem is HBcAg is unstable. It cannot be identified in your investigations and HBcAg instantly crumbles. That is why the only antigen which cannot be found in the circulation would be HBc antigen. So the first antigen to disappear from the circulation is also HBc antigen. So automatically that tells you a statement that anti-HBc antibody will be the first antibody to appear in case of hepatitis B infection. Later, if you look at the HBc antigen which crumbles, it crumbles into another antigen called as HBe antigen. Now, every time you see HBe antigen, then it is an indication that the HBc antigen has been destroyed. Now, when HBc antigen is destroyed, it is an indication that the core is crumbling, the virus is replicating. So, HBc antigen is telling you that the virus is having high replicability. And if the virus is highly replicable, at that point of time, the patient is highly contagious. Now, when this antigen disappears, then its corresponding antibody appears. So if anti-HBe antibody is present, it's an indication that this antigen has disappeared, and this is an indication that the patient is less infectious. So let's have a quick recap. HBe antigen speaks about replicability and contagiousness. If it disappears, then appears the anti-HBe antibody. That indicates the patient is less infectious or contagious. The HBc antigen is the first antigen to appear or disappear. Yes, it is the first antigen to disappear. And when it disappears, immediately anti-HBc antibody appears. HBs antigen is a very stable surface antigen, and if it is present, a live infection is shown. And if anti-HBs antibody is present, then there is clinical cure, or the patient is right now not suffering from infection. Now, anti-HBc antibody can be either IgM antibody or IgG antibody. So, depending upon whether it is IgM or IgG, you can say whether the infection is acute or chronic respectively. That's all. So, this is what you have to understand from the permutations and combinations of different antigens and antibodies. Now, let's look at the first MCQ which we got incomplete. This is both a PSM question and also a microbiology question. It says that among the four options, which one is not actually a part of iceberg submerged phenomena? That is, when you look at the iceberg, the submerged portion, which disease is not a part of the iceberg submerged portion? Iceberg submerging means what? We are focusing on subclinical infection. So the question can be rewritten as, among the four choices, which one has the subclinical course? Which one does not have the subclinical course? So if you look at the submerged portion, the ones which cannot be seen in the community by a clinician, then that can be only one organism, which is influenza. If they're asking you for those which are not submerged and those that are visible, it can be rabies, tetanus, and chickenpox. So subclinical infection can be a property of influenza virus. Why do I say this? Because many times influenza may be subclinical, where the patient himself does not know that he has infection or he has very mild clinical features. But when it comes to rabies and tetanus, the moment, I repeat, when it comes to rabies and tetanus, the moment the clinical features begin, it is having 100% fatality. And so you will not generally have rabies or tetanus as subclinical cases. Chickenpox is a very vocally ready organism. If the organism comes inside, you will suffer from chickenpox, like varicella zoster virus is capable of causing chickenpox. But if a patient is already immunized, in those patients, varicella zoster virus infection can be present, but he will not be presenting himself with chickenpox. But among the four options, influenza virus is the one which can present maximally subclinical focus. So if it is a subclinical focus, then submerged as the portion of iceberg can be a answer for influenza virus. Look at this question. This has been asked left, right, and side and front as many times as possible in the last 7 to 8 years. Almost 55 questions have been raised. These have been taught so many times in the app also. By most of the times when I go for live classes offline and online, I have taught this many times to all the students. Remember, whenever they speak about a male who has urethral discharge with burning micturition, you think of urethritis, right? This can be a sexually transmitted disease. And if pus is found in the discharge, you can think of two organisms. One is gonococcus, which is Neisseria gonorrhoeae. The other one can be chlamydia. Remember, even though chlamydia is an atypical bacteria, it is still capable of producing purulent discharge. Now, in that question paper, many students have told me that they have said on microscopic examination of the urethral discharge fluid, people were able to perform a gram stain which showed gram-negative diplococci. And when it comes to gram-negative diplococci, we have two major groups of organisms, one being gonococcus, the other being meningococcus. And meningococcus is not known for causing STDs, which is capable of causing urethritis, but gonococcus is known for causing STD, which is a part of urethritis. Now, what are the things we have taught in the classroom sessions when it comes to the concepts of STD or in case of Neisseria gonorrhoeae? Remember, the most common cause of urethritis all over the world has to be gonococcus. if I remove gonococcus from the options, then the next most common cause of urethritis will be chlamydia. Because gonococcus takes up the huge load of urethritis cases, if there is urethritis caused by something other than gonococcus, then they are referred to as non-gonococcal urethritis, which is caused by chlamydia or ureaplasma urealyticum. Now, in this case, it's a clear indication that we are discussing Neisseria gonococcus. In case of gonococcus, the drug of choice has to be a cephalosporin. We have discussed this in detail when it came to the concepts of Neisseria, and also when it came to the concepts of virulence factors. We have discussed virulence factors so deeply that what is the meaning of primary virulence factors, where P1 pilus is there for gonococcus, IgA protease is for gonococcus. At the same time, we look at the endotoxins of gonococcus, the invasive properties of gonococcus, and also the gonococcus ability for causing even meningitis and septic arthritis. All these things have been discussed. So please go back and watch the videos for deeper understanding. Cephalosporins second generation and above will be very efficient in clearing gonococcal infection. Now look at this question. A child presents with diarrhea from the stool sample. A virus was isolated. That virus was shown on electron microscopy, and the viruses looked like cartwheel or wheel appearance. Now look at this. Whenever they say wheel appearance, it has to be rotaviridae, rotaviruses. And if they say a child is presenting with diarrhea, you don't have to look beyond rotavirus, because rotavirus is the most common cause of childhood diarrhea among viruses. Norwalk viruses are the most common group of viruses known for causing adult diarrhea. When it comes to adenovirus, this adenovirus will look like space vehicle. Space vehicle shaped viruses, adenovirus. It is capable of causing diarrhea, but it is not as common as rotavirus in causing diarrhea in children. HIV is not the picture when it comes to the electron microscopic image. Enteroviruses are known for causing diarrhea in case of adults. Now remember, because we speak about the wheel, cartwheel shaped viruses in electron microscopy, the answer has to be rotaviridae. Among children under 5 years of age, the most common viral pathogens are rotavirus, norovirus, adenovirus, astrovirus. Astrovirus is star-shaped. Astro. And when it comes to norovirus, it is almost like rotavirus, which is also circular, almost like wheel shape. Let's look at the next question. A patient presents with foot mycetoma that discharges white granules, which on microscopy shows filaments. What is the causative organism? Now, remember, whenever there are white granules or yellow granules or golden yellow granules, one thing that you're very sure is they are not black granules. They are not black discharge. If it is not black discharge in case of mycetoma, then it is not eumycetoma. That brings us to the diagnosis that this is a case of actinomycetoma. And if it is a case of actinomycetoma, the organisms which can cause actinomycetoma can be Actinomycetes israeli, Actinobacillus, Nocardia, Staphylococcus aureus. Apart from that, you can also take into consideration Pseudomembranous boydii. But there is a very clear understanding that Pseudomembranous boydii is a fungus, which makes Alleschieria boydii the bacteria. Now that brings us to another understanding that eumycetoma are mycetomas caused by true fungus, while actinomycetoma are the mycetomas caused by false fungi or true bacteria. Now, when it comes to Staphylococcus aureus also capable of causing mycetoma, remember, you will not be seeing filaments of the organism, you will be seeing gram-positive cocci in clusters. This is the pathognomonic statement for Staphylococcus aureus being diagnosed. When it comes to Nocardia astroides and Actinomycetes or Actinomycetes israeli, both of them are capable of producing filamentous picture. Why? Because Nocardia is gram-positive Actinomycetes is gram-positive. Nocardia is strictly aerobic. Actinomycetes is anaerobic. But both of them are beaded filamentous bacteria. The only way by which you can differentiate Nocardia from Actinomycetes is that Nocardia is partially acid-fast, while Actinomycetes is non-acid fast. But both of them are capable of being the causative organism of this picture. Because Actinomycetes is not asked in this question paper, we can fix for Nocardia asteroides. What about histoplasma? Histoplasma is not known for causing mycetoma because mycetoma is a type of subcutaneous mycosis. Histoplasma is known for causing systemic mycosis involving lung or even the blood picture. When it comes to Sporothrix skincai, this is also capable of causing a subcutaneous mycosis, but that condition is called as sporotrichosis. And when it comes to sporotrichosis, which has been asked many times between 2017 and 2020, they speak about a rose thorn that is pricking the patient. And you will be able to see eruptions, ulceronodular eruptive lesions, which are painful along the line of lymphatics. That statement describes sporothrix. So it is not staphylococcus, it is not sporothrix, it is not histoplasma, it is nocardia. Remember that. Eumycetoma is caused by fungi, actinomycetoma is caused by bacteria. If it is a bacteria, it is not black discharge, it will be white granules or yellow granules or sulfur granule discharge. Look at this question. A female patient from Bihar presents with fever, dark pigmentation of skin, weight loss, and hepatosplenomegaly. On investigation, pancytopenia is noticed. Which of the following can be the vector? Now, you may not be able to make a stunning diagnosis in this condition, but we can arrive at a diagnosis saying that it can be visceral leishmaniasis, or it can be Kala Azar, which is PKDL. Post-Kala Azar dermal leishmaniasis. Why do I say that? Hepatosplenomegaly is the case that is to be taken into consideration. Remember, in case of leishmaniasis, the world's biggest splenomegaly can be noticed. Leishmaniasis shows the world's biggest splenomegaly among all infections. Now, if there is a pancytopenia, then bone marrow infiltration can be expected. The weight loss can be noticed and dark pigmentation can be noticed, which all can point towards leishmania. Assuming this condition is leishmaniasis, then the answer has to be phlebotomine sandfly. Phlebotomine sandfly is the vector for the condition, and for more amount of detailed analysis of what can the ticks spread, what can the mites spread, and what can the fleas spread, watch the rickets hill chapter and the arthropod bone infectious chapter so that you will be able to answer every question properly from this. This has been covered through and through thoroughly in case of your diseases of videos. Now let me answer one more thing for you. Now, when it comes to leishmaniasis in the old world, it is phlebotomous. For the future references, if at all they ask you in new world, what is the vector for transmitting leishmania, then the answer can be Lutzomyia. Remember, this is Lutzomyia, this is phlebotomine sandfly. And sandfly vector, when it bites, it is capable of causing a local invasive lesion. Because of that, the lesions will have rounded edges, elevated rounded edges in the ulcer, and from the central pore area where this proboscis of the sandfly has penetrated, the organism leishmania can travel inside. When it comes to this Lutzomia, this is found in the New World, capable of spreading leishmania in the New World. Now look at this question. A man presents with diarrhea and was diagnosed to have infection from E. coli O157H7, where H stands for what? This is a very low level of understanding the question. If you had followed our classes very deeply, we have discussed in detail what are the different types of E. coli, and I had told you EHEC and EIEC are the only two E. coli who are capable of causing consistent dysentery or hemorrhagic colitis. Now, EHEC is capable of using verocytotoxin to cause death of the colonic cells, because of which bleeding happens into the stools to cause dysentery. And in case of EIEC, it has verocytotoxin plus also it has invasin. It has a dual weaponized system which is similar to that of shigellosis. We have also told you that EHEC and EAEC are known for causing dysentery, but they are not only known for causing dysentery, all dysenteries are basically diarrhea along with that of blood. So many students who came and said, sir, they have said diarrhea, how can I take it into consideration for EHEC, because EHEC is supposed to cause dysentery, right? No, EHEC can cause diarrhea also when it is mildly virulent. And if it is EHEC, the meaning O and H are very simple. We have discussed that in case of gram-negative enteric bacilli, the antigenic system or the naming of the antigens has been very simple. H antigen is flagella, K antigen is capsule, whose spelling right now is capsule, CAPSULE, and O antigen represents the outer membrane of the gram-negative organism made up of the lipopolysaccharide itself. So here the H stands for flagella. Right and right, very simple question. Next question, an ICU patient with catheter in situ. The catheter is right now present in the urethral meatus or through the urethra, and that patient is having fever and UTI. On gram staining, gram-positive cocci were noticed, is what some people told me. Some people said gram-positive ovoid budding organisms are noticed. See, if you say cocci, it cannot be a fungus. If you say ovoid budding, it cannot be a bacteria. So it's a very simple logic. If you say, sir, gram positive is the word given now, sir, so it has to be Staphylococcus and Streptococcus. No. Candida is also gram positive. We have discussed in detail about the virulence factors of all the organisms, and I've told you what exactly is pus. If an organism is capable of producing pus, think about the pus being a culmination of dead neutrophils plus or minus alive neutrophils plus dead or alive bacteria. Along with bacteria, think of the fungi called as Candida and Aspergillus plus the plasma fluid plus the proteins. This combination is called as pus. And when I taught you this in the classes, I already told you Candida and Aspergillus are the two fungi who can behave like gram-positive bacteria. Now imagine if at all the question paper carried the word gram-positive cocci, think of Staph epidermidis more than Staph aureus when it comes to the urethra. And if it is urethra with the catheter, remember the most common organism which is found as a saprophyte on the human skin is epidermidis. In case of your perineal region, both epidermidis and saprophyticus are equally present. Some authors say saprophyticus is more common than epidermidis in their presence as saprophytes. Next comes aureus. So among these three options, think of epidermidis, then followed by aureus. But if they say ovoid budding, it has to be the yeast-like fungus called as Candida. So choose your questions well, read the question properly. If you can recollect it was cocci, it can be Staph epidermidis and aureus. If it is an ovoid budding organism, it is Candida. Look at this question. Microfilariae with no nuclei in the tail tip. I have told you innumerable times in the classes that this question has been asked so many times that they are not even bored of asking the same question 10 to 15 times more. And it is not going to be a surprise if you see the same questions in the upcoming years also. Microfilariae, no tail tip. I had told you when it comes to Wuchereria bancrofti, look at the last three letters, FTI, free tail tip. This is what I taught you in the class. So free tail tip means when you look at the organism and the sheath is stopping here, beyond the sheath, there is no nuclei at all. From here to here, the tail is not having nuclei. But when it comes to Brugia malayi, you will be able to have two nuclei in the tail tip. Now look at this picture. The microfilaria, if it is Wuchereria bancrofti, is sheathed, its body is gently curved, and the tail is tapered to the point. Now, in this image, you can see the organism here. Now, this is where you think the organism ends. But if you watch very carefully, empty sheath areas can be present. Now, from this area to this area, you can see the tail. And watch very carefully, there is no nuclei at all. These are the nuclei. The dark colored structures you see, the nuclei stop well ahead of the tail tip. The nuclear column is loosely packed and the cells can be visualized individually but do not extend to the tip of the tail. It has been asked almost 6 to 7 times in the last 5 to 6 years. So please be careful with this question again. Now, for your reference, look at other organisms also. When it comes to Brugia, here, this is the sheath and you will be able to see the nuclei present till here. If this is the area, the nuclei can be present till here. When it comes to Wuchereria, you will be able to see this much amount of space or this much amount of space where you will not be able to see the nuclei. Okay, when it comes to lower here, lower, although stained, the sheath remains uncolored. Look at this. Here you are able to have an idea about the sheath, but here there is no proper demarcation of the sheath. Have a look at this. The sheath is not clearly demarcated and the nuclei are appearing pale, but they are also found at the very tip of the organism. When it comes to Onchocerca, the beauty is both the anterior and the posterior poles are free from the tail tip, free from the nuclei. Look at this, no nuclei here, no nuclei here in case of Onchocerca volvulus. So the other important point is when I spoke about this lower, it is sheathed, but the sheath is not actually colored. So it is uncolored sheath. But in case of Onchocerca volvulus, there is no sheath at all. So this is an example of unsheathed nematode, which is a filarial nematode. Next question. A 25-year-old male has a proper clinical presentation that indicates meningitis. This is what my students told me, and it may be like fever, headache, neck rigidity. I repeat, fever, headache, neck rigidity. This triad will point towards meningitis. But they also added there was an altered sensorium, which means the parenchyma of the brain can be involved, and Kernick's sign was positive, Brodzinski's sign were positive. It's a clear indication of meningitis. But if they say it is high grade fever, then it has to be a pyogenic meningitis. If it is mild to moderate grade fever, it is atypical meningitis. And they say this patient or this 24-year-old male had previous bouts of meningitis in childhood. The rash is present all over the body, including the palms and the soles. What is the pathogenesis? Among this, many students were not able to recollect the pathogenesis for the remaining two options, and they don't even remember what was there in the option D. All were able to say it was Neisseria meningococcus, and they were able to say meningococcus can actually cause recurrent meningococcal meningitis when the patient suffers from membrane attack complex defect. This can also be written as any kind of deficiency of late acting complement factors. The late acting complement factors can be any factor between C5 to C9. It can be more than one, it can be all of them, or it can be even one of them. C5, C6, C7, C8, C9. If any of them is deficient, the formation of membrane attack complex on the surface of the organism is not possible, because of which the organism can thrive. See, meningococcus as an organism, gonococcus as an organism have overcome a lot of evolutionary distress offered by the human being. The one area where they are still vulnerable to is in the human immune defense response. They are still vulnerable to the membrane attack complex. So if a patient is having congenital defect in the MAC formation, then they will be more vulnerable for Neisseria meningococcal infection. That is why we expect altered sensorium in this patient. And that is why you expect repeated previous bouts of meningitis in childhood also. Also remember, meningococcal meningitis is the most common meningitis in adolescent age group between 3 to 14 years of age. Okay, now look at this. They said a man is presenting with complaints of rashes over the perianal region and back. The picture of the scalp was shown. Mild alopecia pattern was seen. And there was a question or a difference between psoriasis and syphilis. This question was incomplete. But let me tell you, if there is any kind of itch or pain in the perianal region, and if they are speaking about a helminth, think of entropius. If in case of scalp lesion, you have dandruff-like equivalent, think of dermatophytosis, which is mycology. If it is syphilis, it is capable of causing a mild alopecia pattern. This picture is incomplete for me. For those people who can complete this question, please let me know. Farmer complains of fever, retroorbital pain, and there is tenderness in both the calf muscles. Bilateral conjunctival suffusion. What is the diagnosis? See, when it comes to malaria, fever can be mentioned. But they have to speak about the breaking of fever, whether it is a tertiary malaria, quarter malaria, etc. The fever is there for how many days, when does the fever subside, all these things should be said. Chills and rigor can be actually explained in case of malaria, but in case of malaria the conjunctival suffusion is not very common. Now look at dengue. Dengue fits perfectly because fever, retroorbital pain, calf muscle tenderness can also be seen. Now, the point here is dengue is not known for causing conjunctival suffusion. Dengue is known for causing breakbone fever. The fever can actually be very painful in such a way that the pain can feel as if the patient's bones are breaking. But if at all you look at influenza, influenza does not cause such a kind of severe picture. Now, the answer can be Leptospira. Why will I actually sway towards Leptospira is the question speaks about the farmer. You can argue dengue can happen in the farmers also. The farmers can also be bitten by the mosquitoes of the dengue spreading nature. Yes, of course. But when there is a farmer, and even if they have not mentioned about the rats, rice field, and rainfall, the 3R disease is leptospirosis, which is capable of causing retroorbital pain, but the clinical feature is conjunctival suffusion. Conjunctival suffusion, retroorbital pain, and if at all they have mentioned jaundice, then it can be a clear case of leptospirosis. Okay, so a similar case here, a less than 10-year-old child with complaints of diarrhea, increased pain and itch in the perianal region. Mother notices worms crawling out of the anus during the night when the pain and itch were more in the night, right? So you think of Enterobius vermicularis. Some people said that the organism's picture, that is the Hellman's picture, was shown. Some people said the eggs were shown. Whatever the fact is, if the eggs were shown, it may look like a lens and it is not bile stained. It may even look like a coffee ground. I mean, a coffee bean. It may look like a coffee bean. It may look like a lens where one edge is flattened, the other edge is curved. And why is one edge flat and the other edge is curved? Because the larva actually bends over inside the egg. That is why the larva, one area can actually have a flat zone, and when the larva bundles upon itself, it gives you a curved discoloration, and because of which the organism can be noticed as a curved entity. So Enterobius vermicularis is known for causing auto-infection also when the child is unable to tolerate the itchy sensation in the perianal area. He will try to scratch his perianal region, and the worms or the eggs can be deposited in the nail bed. The same child, when he tries to eat his food, even after washing his hand, the eggs may be ingested. So auto-infection is a possibility in Enterobius vermicularis. Then they spoke about an image of CT of hydatid cyst of liver, where it was similar to that of water lily sign on ultrasound. That is, they said the picture looked like the water lily sign of ultrasonogram, but they had shown about the CT scan of hydatid cyst of liver. They had spoken about the Garbi classification. This would be discussed as a part of surgery questions. Okay, now this question, some people said sickle cell anemia, some people said thalassemia, but I believe the question could have been thalassemia or hereditary spherocytosis. No matter what it is, the child is having some hemoglobinopathy, and that particular child is treated with blood transfusion, and that child is having sudden development of rashes all over the face. If those rashes are reticulate in nature, which can have a network like lacing appearance, then it may give you a slapped cheek appearance. And when you speak about slap cheek appearance, which virus would you think of? It is obviously parvovirus B19. And that parvovirus B19 has special tropism towards erythroid progenitor cells, not the freshly born RBCs or the mature RBCs. It is the progenitor cells that are under effect. If at all the parvovirus B19 affects the bone marrow or it affects the progenitor cells, it can cause transient aplastic crisis, or it can even cause, in immunosuppressed patients, it can cause pure red cell aplasia. So remember this part. This is parvovirus B19. It is a DNA virus. It is the smallest virus. Okay, what about the cholera vaccine? See, cholera vaccine is taken orally. The oral vaccine is a bivalent vaccine. Now, in PSM, there has been enough description on the cholera vaccine. Look at this part here. See, you have Dukoral, Sancol, Evicol. Dukoral is monovalent And here you will be able to have Sancol, which is bivalent. Uvicol is similar to Sancol, is what they say. When it comes to Sancol, bivalent is having the strains of antigens from O1 and O139, and two doses are given 14 days apart. And booster dose is given every 2 years. So in this option, a divalent or a bivalent vaccine, not given as a single dose, but given as two doses, one on the first day and the second one on the 15th to the 14th day, with 14 days gap between. And most of the PSM books have given that the space between the two doses of vaccine should be more than or equal to 7 days. Ideally, it should be less than 6 weeks. These are the 2 points you have to remember, because if you take time more than 6 weeks, the effect of the first vaccine will start actually fading. But if you give it within 7 days or less than 4 or 5 days, you have not given enough amount of spiking effect of the second antigen. So give it after more than or equal to 7 days, but ideally it can be given on the first day and on the 14th day. Divalent vaccine, 2 strains of O1 and O139. Okay, this is a very commonly asked question. It has been asked so many times and has actually gone out of vogue. We have discussed this many times in parasitology also. A contact lens user suffers from keratitis. Whenever they say contact lens, think of the soft contact lens. And soft contact lens user, if he is not able to wash his contact lens properly before applying them, or he uses running tap water, the fresh tap water, if it is contaminated with acanthamoeba, then acanthamoeba culbutzoni based keratitis is very common. And why is it called as acanthamoeba? Because of the acanthocyte similarity. What is acanthocyte? In case of RBCs, if the RBCs are showing spike-like projections outside, you call them as acanthocytes. Now this is the trophozoite version of the amoeba, and look at these projections. These projections indicate that it is acanthamoeba. Naegleria fowleri is a free-living amoeba. Balamuthia mandralis is also a free-living amoeba, but both of them are not known for causing keratitic lesions in soft contact lens users, but all three are capable of causing meningoencephalitis. Nugent score is abnormal in. You don't have to focus on this area. Nugent score is done in case of bacterial vaginosis. This is all you have to remember. Now let me tell you a few things. Nugent score is a Gram-Stein scoring system, and this is for vaginal swabs to diagnose bacterial vaginosis. It is not done nowadays, but for the sake of completion and for the sake of remembering for the future, you have to know this. The Nugent score is calculated by assessing for the presence of large gram-positive rods or small gram-variable rods or curved gram-variable rods. Who are the large gram-positive rods? Lactobacillus morphotypes. And if you look at gram-variable rods, look at Ganella vaginalis. In case of gram-variable rods, look for Mobiluncus. Now, a score of 7 to 10 is consistent with bacterial vaginosis. Now, the Nugent score is very rarely used by physicians because it takes a lot of time. Bacterial vaginosis diagnosis is done by evaluating the pH. Now, in the paper, if the question, they say there is a foul smelling vaginal discharge, think of this organism, bacterial vaginosis, and it is caused by Ganella vaginalis, also referred to as Haemophilus vaginalis. And the other organisms which may be found as a part of mixed flora can be Bacteroides, Mobiluncus, and Mycoplasma hominis. Okay, if you have a score, Nugent score of 0 to 3, it is negative for bacterial vaginosis. 4 to 6 is indeterminate. 7 plus is indicative of bacterial vaginosis. Now, there is something called as Amsel criteria for bacterial vaginosis, which takes into consideration the pH, and also it evaluates for the presence of clue cells, white discharge, and with an order of amines after mixing with KOH. That is KOH plus the vaginal discharge. If KOH is exposed to that discharge component, then the source of ammonia can be liberated. Ammonia pungent smell will come out, which is the idea of the amines. And pH value plus evaluation of the clue cells and the white discharge and the order of amines together can be coming for the Amsel criteria for making a diagnosis of bacterial vaginosis. A patient with complaints of fever and burning micturition, urine culture showed a novobiocin-resistant microbe with counts of more than 10 to the power 4 colony-forming units. Next step, they say clean catch midstream urine, commensals, it may not be necessary to treat them. It is a 3 early morning samples can be done. All these things can take a back seat If you understand that the patient is having burning maturation, that is, symptoms are present. If symptoms of urethritis or UTI are present, then more than 10 to the power 4 colony forming units is enough to make a diagnosis of UTI. If the diagnosis of UTI is done, then you have to send it for antibiogram and start the resistant microbe being treated. You have to start the treatment of the resistant microbe. If there is no way of saying resistant, you may think of staphylococcal species, but take into consideration whichever the organism it is and start immediately the treatment for UTI. And if the UTI is not treated for a long time, it can cause complications of local histological architectural change. Okay, look at this. An infant with clinical features of fever and CNS had bilateral chorioretinitis and intracerebral calcification. They say infant. So, if at all you think of a child acquiring the infection from the mother's womb, you think of the torch complex, out of which the first one among the torch complex is toxoplasma. So the child may have fever, CNS features, the CNS involvement is noticed, chorioretinitis and intracerebral calcifications can be a part of toxoplasma and CMV, but when they speak about hydrocephalus, and if it is the intracerebral calcification in a vague pattern which can be found all over the area, then the answer would be toxoplasmosis. This is a case of toxoplasmosis. Look at the chorioretinitis. CMV retinitis can also be noticed, but toxoplasma chorioretinitis is more common than that of this. Intracerebral calcifications can point towards toxoplasmosis. Now, this question, I can treat it as a combination of both biochemistry and microbiology because of urine stones. Now, look at the top part, this is biochemistry. Look at the bottom part, this is microbiology. A renal colic case, repeated attacks of the colicky nature is noticed. Other investigations are normal. When you go for urine examination under microscopy, hexagonal stone is seen. If the stone is hexagonal, think of cystine. Cystine in the urine is an example of cystinuria. Cystinuria can produce cystine in the urine, and this can be a case where cystine reabsorption from the renal tubules are failed because of cystinuria can be seen. At the same time, you can have hypercystinemia, which is rare, but the cystine levels are high in the blood because of which they're spilling out in the urine to form cystinuria. This is also possible. At the same time, cystine reabsorption is normally failing in case of renal tubules. That is why cystine is coming out in the urine. There also you can find crystals. Now, look at the next question. This is a microbiology question. A patient has Proteus infection. Plain X-ray of abdomen was done showing a large stone in the urinary bladder. The stone is made up of what? See, Proteus is a urease positive organism. It means the tubular fluid, the fluid that has come out of the filtrate, will become alkaline. Why? Because urease will start releasing ammonia. Now, because of excess amount of ammonia, the pH is alkaline. Now, the urine is alkaline. Under alkaline pH, acidic compounds will be easily ionized and they are easily dissolvable. If they are easily ionized and dissolvable, they'll be lost in the urine. They will not be retained back to form stones. So no acidic stones can be seen in case of acidic nature. So calcium oxalate cannot be noticed. But the most common infection that can happen in case of Proteus infections would be calcium phosphate, triple phosphate stroate stones. Triple phosphate stroate stones. Now, how will this stone of biochemistry look? It is how this looks. This is a hexagon. 6 edges are noticed, 6 angles are seen, hexagons. Now, cystine stones are associated with cystinuria, not in case of Proteus infection. Calcium oxalate stones are commonly seen in conditions such as hypercalciuria, and they are not found in case of Proteus infection. And there is a saying that if you take a lot of tomatoes are rich in oxalic acid, because of which oxalate stones of calcium formation can be noticed. Xanthine stones are very rare and they are associated with xanthinuria. There were a few questions in mycology also. One was a very simple question. They said desert rheumatism is caused by which organism? Desert rheumatism is also referred to as valley fever, and this is caused by Coccidioides immitis. Now remember, Coccidioides is spread through arthrospores, a type of asexual spores. And these organisms are present deep in the soil. And they come out into the atmospheric air when there are cataclysmic events or natural disasters like earthquake, volcanic eruptions, tsunamis, movement of tectonic plates, etc. And under the debris area, those people who are walking through the debris as survivors will be inhaling these organisms easily, and this coccidioides is capable of going to the brain if it is being inhaled. At the same time, coccidioides is a part of the dimorphic fungi who are known for causing systemic mycosis. And this is very common in the desert region of the Colorado Plateau in North America. That is what is referred to as desert rheumatism. And because that area is a deep valley, you call it as valley fever also. So remember, coccidioides is known for causing desert rheumatism, which is also referred to as valley fever. Paracoccidioides is known for causing South American blastomycosis. Histoplasma is known for causing Darling disease. Now, what is the other question which is similar to this? They said a thick cell-walled fungi, lot of spores are released. The fungus was showing broad-based budding. It infects the lung to produce pneumonia-like symptoms. See, whenever they speak about a dimorphic fungus which is inhaled and enters into the lungs to cause pneumonia-like features, then the dimorphic fungi you think of should be histoplasma. And we have discussed in the class so many times that histoplasma runs a clinical course parallel to that of tuberculosis in the early stages. Both of them are inhaled and both of them are capable of having a very slow onset, and they are capable of activating the CMI. Both are capable of causing granulomatous changes. But histoplasma is a fungus, MTB is a bacteria. Histoplasma spores can be inhaled while MTB bacilli are being inhaled. Histoplasma can be a dimorphic fungi while MTB is an acid-fast organism. But in this case, they are telling you the fungus is having a broad-based bud. It means when you try to draw the picture, it is how the picture will be. Now this looks like the figure of 8 appearance, or it can be snowman appearance. Both of them point towards blastomycosis caused by blastomyces dermatidis. As the name suggests, dermatidis is known for causing skin lesions also, which can produce squamous cell-like carcinoma like lesions on the skin, verrucous lesions on the skin. Now, blastomyces, paracoccidioides, coccidioides, histoplasma all can run a parallel clinical feature which can be systemic mycosis. Because these are almost similar kind of clinical features, because blastomyces is very common in North India, it is called as North American blastomycosis causing organism. Such a similar case is caused by paracoccidioides in South America. It is referred to as South American blastomycosis causing organism. Coccidioides is desert rheumatism, as we saw in the previous MCQ. Histoplasmosis is known as Darling disease, but because they have said broad-based lung or broad-based fungi yeast, you have to go for blastomycosis. Now, students said there was one more confusing MCQ where there was a picture based on a hair shaft. Some students said some spores were present in the hair shaft in the center of the hair shaft. Some people said they were present outside the hair shaft, not inside. Remember, if the fungus is known to attack hair shaft, it has to be a superficial mycosis causing fungus. The superficial mycosis can be of three major types, one being tinea, the other being dermatophytosis, the third being candidiasis, out of which the involvement of hair can come under dermatophytosis. Under dermatophytosis, you have trichophyton, epidermophyton, and microsporum. We have discussed in this class n number of times. Trichomyton has tri. It means all the three can be involved. Skin, hair, nails. In all the three, because they're dermatophytes, derma, the skin has to be involved. So, Phyton ends with N. So here in epidermophyton, skin and nails are very common. In case of microsporum, skin and hair will be involved. So if the entry of the organism is inside the hair shaft, it is referred to as endothrix. Thrix means involvement of the hair shaft. If it is present only on the outer surface of the cuticle of the hair, you call it as ectothrix. Now, both ectothrix and endothrix are commonly caused by trichophyton. But students said that trichophyton was not there in the choice. If trichophyton is not there in the choice, then you have to settle between epidermophyton and microsporum. Because epidermophyton is not consistently known for causing hair infections, you settle for microsporum. But for the future references, look at ectothrix. When it comes to ectothrix, trichophyton, violaceum, tonsurans, sconlani are commonly known for causing endothrix. So you will be able to see canis, audoni and mentagrophytes known for causing ectothrix. These three are also trichophyton only. Both ectothrix and endothrix, trichophyton. Trichophyton tonsurans, violaceum sconlani. Trichophyton tonsurans, violaceum sconlani can cause endothrix. Trichophyton canis, audani, mentagrophytes are known for causing ectothrix. Because trichophyton was not given in the choice according to the students, then we settled for microsporum. In immunology, there was a question. They had asked about the mode of inheritance, and they had showed a pedigree chart, it seems. If it is to be believed, students said the pedigree chart showed X-linked inheritance. And they had given two diseases, one being Wiskott-Aldrich syndrome, the other one being achondroplasia. Many students said they don't remember the options in between. So Wiskott-Aldrich syndrome is an example of X-linked inherited disease, while achondroplasia is an example of autosomally dominantly inherited disease. I had told many times, when you come towards immunology, especially in case of primary immune deficiency disorder, please remember the inheritance patterns also. For example, in case of severe combined immunodeficiency, you have two types. One of them will be ADA deficient. So one can be X-linked, the other one can be autosomal. So that kind of inheritance is also important for us to be remembered. Okay, now what are the other questions where patchy information has been obtained by me? Here they said, in case of an immunological condition where immunofixation method was done, they said the patient was elderly, back pain was a clinical feature. Some people said the feature was there, some people said the feature was not there, and the electrophoretic pattern was showing an M spike. Electrophoretic pattern shows M spike. So what was the diagnosis? Obviously, whenever you see M band, you think of multiple myeloma. Now, students were arguing with me saying that, sir, multiple myeloma, you will be having the band in the IgG region, no, sir. And some students were saying there was immunofixation technique where the IgM band was looking more darker. See, in case of electrophoresis or these kind of patterns, the width of the particular band is not important to tell us the concentration. The darkness or the intensity of the color tells you the concentration. So if people said IgM was darker or IgG was darker, now please remember, in case of electrophoresis, if you're looking for multiple myeloma, after the albumin being seen, alpha 1, alpha 2, beta 1, and beta 2, there comes gamma, right? Generally, in the area where the beta is ending and the gamma is beginning, that is the best place for the M band to spike. So, M band can be found between that of the beta region and that of gamma region, but mostly people think it is in the gamma region because of the gamma globulins. Now, why is this confusion whether it is between beta and gamma? Because multiple myeloma is actually a plasma cell dyscrasia, right? What is the one thing we have taught you in both biochemistry and microbiology? The concept that in case of multiple myeloma, the plasma cells are producing light chains of the antibodies only. Light chains of antibodies will tell you either they are the kappa or the lambda chain. Either the kappa or the lambda chain alone, but never both. Because we are not having the tumor which can produce the heavy chains more, but we are having the tumor that produces the light chains more, we are having the zone between that of IgM and IgG. So if you had seen the picture, if the dark zone was there in the IgM region, please choose the answer IgM. If the dark region was in the IgG area or in the gamma region, you can go for IgG. That's all. There's nothing much to discuss or have a confusion over. Now let's look at other general MCQs. There was a question about ADA levels being low, also thymus gland absent. These two things were told to me by the students. So you can think of a severe cell mediated immune deficiency, but because ADA levels are also low, you can think of severe combined immunodeficiency. See, thymus gland is completely absent in one more condition. What is that? It is DiGeorge syndrome, which can speak about either thymic aplasia or thymic dysplasia. Now, in this case, remember, the patient will always have a clinical feature which is recurrent infection. So, when they want to drive home a point, the examiners, if they want to drive home a point that there is an immunodeficiency disorder, they obviously have to state that the patient is having recurrent infections. So, adenosine deaminase is important. Why? Because in case of purine metabolism, adenosine has to be deaminated for inosine formation and further catabolism. But if this adenosine deaminase enzyme is absent, then the deamination stops, because of which adenosine will start increasing inside the leukocytes. And adenosine is toxic to the fresh cells, immune cells, especially the thymic lymphocytes. So they can be toxic and can be lethal to the thymic lymphocytes because of its cell mediated immunity can fail dramatically. Okay, what else? There was a question when it comes to typhoid. Students had said that they did not know what kind of investigation to choose. See, if it is typhoid, ask yourself if the patient's clinical features said the patient had food from outside. This can be one of the important history of the patient, and he may have fever which can be remitting, or it can show step ladder pattern. Abdominal pain can be noticed. Diarrhea can be seen. In some cases, dysentery can be noticed. And remember, yes, typhi is one special organism after Entamoeba histolytica to exhibit erythrophagocytosis. Also, S. typhi is known to attack the Peyer's patches present in the mesenteric border. All these are points that can favor typhoid. Now, the student said the clinical features were very obvious on the 5th day. Some people said it was on the 4th day. Some people said it was on the 3rd day. But Third day investigations may not actually be fruitful, but if you take fifth day into account or sixth day into account, you can say we are discussing it in the first week. If you want to know what kind of investigation should be run in case of typhoid, go back to the age-old mnemonic called as BASU. I have taught you in class, don't just write it as first week, second week, third week, fourth week investigations. Try to understand it as end of each of them. End of first week, end of second week, end of third week, and end of fourth week. For example, if I say eighth day is second week, but it is still end of first week. Fifth day is also end of first week. So when it comes to the fifth day, you have to go for blood culture. A speaks about antibody. So some students were asking me, why don't you do Vidal? Vidal is done because Vidal is an antibody based test or serological test. So it can be done only on the second week or the end of second week. S is stool culture, U is urine examination culture. So the best answer for the fifth day of a typhoid case has to be your first week. Okay, what else? Now, there were other questions that said genitalia lesions, where there were two important points. One was painful genitalia lesion. The other one, the lesions were vesicles in nature. If they say painful genitalia lesions and vesicles in nature, think of unprotected sexual intercourse. That speaks about an STD. An STD with a painful genitalia lesion can be any of them. The one of the painless diseases can be chancre caused by syphilis. Almost all the others are painful lesions only. But when the lesions are painful and the lesions are surrounded by vesicles, then you have to think of herpes simplex virus. If it is herpes simplex virus, you can go for Zanxmia, multinucleated, marginated, giant cells can be noticed if you go for histopathological examination. Herpes simplex virus, two types, 1 and 2. Generally, 70% of herpes simplex virus cases are above the belt, oral lesions, and perioral areas. If you look for HSV2, 70% of lesions are below the belt, which are genitalia lesions. And HSV1 is very commonly known for causing encephalitis. HSV2 is also capable of causing encephalitis. At the same time, herpes simplex virus is known for causing aseptic meningitis. The recurrent meningitis can be referred to as Mollaret's meningitis in case of herpes simplex virus. This has been discussed n number of times. While herpes simplex virus is most commonly known to cause spontaneous encephalitis in the temporal lobe. These are the things you can expect in the upcoming exams. Okay. Next, you had one other question in microbiology where they said a patient was a traveler through the seas. Or some people said it was coastal area. Some people say fisherman. Now, no matter what it is, if he's traveling through the seas or if he's meeting with the brackish water, that is saline water of the seas, then think of a microbe which is capable of surviving high concentrations of NaCl. Okay, this is the clue to begin with. But they also said the traveler had consumed oyster. Oyster is the food from this area. It is a part of sushi. Sushi is raw or undercooked or poorly cooked or uncooked seafood. So that means if you are ingesting this seafood which is raw, undercooked or uncooked, then whatever organism this food is carrying, it can directly have access into the human being. So they had given options of S. typhi, Staphylococcus aureus, Vibrio cholerae. Some students said Vibrio cholerae was not given. Some students said Vibrio cholerae was given. Along with that, Vibrio parahemolyticus were given. The moment I heard parahemolyticus, I was very, very happy because both the Vibrios are capable of surviving in seawater. But when you speak about oyster ingestion, and if you speak of sushi-induced attack on the GIT, because of which abdominal pain as a clinical feature is noticed, along with that, the patient has vomiting and diarrhea, then it is a case of food poisoning caused by sushi, then you have to think of nothing beyond parahemolyticus. This parahemolyticus can actually release a heat labile toxin which is capable of causing diarrhea. At the same time, this parahemolyticus is capable of showing invasive property because of which it can cause mild bleeding from the GIT, which may be leading to dysentery also. Apart from that, if you want to understand the pathogenic focus of Vibrio parahemolyticus, you try to grow the organism on Vagat Suma blood agar. If the Vibrio parahemolyticus is pathogenic and highly virulent, it is capable of causing hemolysis of Wagatsuma blood agar, which is referred to as Kanagawa phenomena. So check whether you came across these words in the question. I'm not very sure because some students say they found these words, some students say they don't remember having seen these words. But as a whole, if you have to summarize this, focus on the travelers, especially in the sea coastal fishermen area. Brackish and saline water can take into consideration both the vibrios. But if it is the sushi induced intake of the organism, then it is Vibrio parahemolyticus, and that organism is also capable of bleeding, causing bleeding in the GIT. Apart from that, it can cause abdominal pain and vomiting. How can you rule out Vibrio cholerae in this? Because Vibrio cholerae never causes abdominal pain. So painless diarrhea, which is capable of causing intense dehydration within quarter of a daytime, so that the patient dies because of dehydration alone, is the property of Vibrio cholerae. Vibrio parahemolyticus may cause diarrhea, but it won't cause very intense dehydration. Instead, it can cause abdominal pain and mild bleeding and dysentery. So think of Vibrio parahemolyticus. Wagatsuma blood agar hemolysis is called as Kanagawa phenomenon. So with this, we have come to the conclusion of microbiology discussion. Dear students, try to learn microbiology as deeply as possible. Try to understand the concepts and the virulence factors of each organism. Start from the morphology of an organism, and once you understand the morphological features, what is so unique about the morphology of each organism, which will reflect in the form of pathogenesis. And that pathogenesis is the microscopic level, which can actually reflect as the macroscopic clinical feature. Once you know which part of your body is showing the clinical features, you will know what kind of specimen or samples to be collecting. And when you know what kind of samples to be collected, you will know what kind of investigations to run. And when you learn all the organisms and their investigations in culture media, microbiology is as cool as possible for you. You can integrate microbiology into any kind of clinical discussions, which can be a part of medicine, surgery, OG, pediatrics, PSM, ophthalmology, ENT, etc. And even you can explain microbiology with the help of biochemistry. So deep integration and wide integration can happen with microbiology. So read them very much. We have discussed that in integral fashion with CBME syllabus as the prime focus. And in our Manipal Meddays app, we have gone for the integration. We have gone for the CBME based syllabus. It is next compatible, next ready, and also NEET PGN, INICT, and FMG ready. So for future discussions, please be there with us and try to have a download of this particular app. Learn from our best kind of teachers who are available on the Manipal Meddays platform. All the very best for your future successes.